2026. Today we have a local boy doing our rounds. Dr. Ilhan has kindly offered to speak to us about an area that he is personally interested in and runs a clinic down at South Health Campus to look at, and that's common arrhythmias and the genetic basis of them. Today's talk is entitled Genetic Clues in Common Arrhythmia Presentations, and this is certainly an area of a lot of advancement recently, and we look forward to what you have to say, Erkan.
Thank you, Andrew. I hope people are hearing me well in the Zoom.
Yeah, can you hear us?
Yes, Andy, I can hear you. Thank you. Okay, no relevant disclosures for the presentation, but I am mainly a clinician. So basically, I am taking care of only Homo sapiens in the inpatient or outpatient setting, in the OR or in the EP lab. I do not generate much work in silico or in the dish. My outline and objectives will be basically to discuss some monogenic cardiac conditions today. And those conditions will not be like well-established phenotypes like HCM or multisystem conditions like amyloidosis or syndromic presentations like long QT syndrome and deafness. It is clear that it is autosomal recessive presentation of long QT syndrome or some other congenital heart conditions. The cases I am going to present will be mostly more challenging to diagnose, and they present with arrhythmia, common arrhythmias initially. I brought some cases from my own practice with atrial fibrillation, flutter, PVCs, and AV block. I think those are common arrhythmias that cardiologists, internal medicine specialists, and family physicians face regularly. Those cases will bring us to a few genetic conditions. I chose those because they are relatively common or they are very interesting, but those are only a piece of genetic heart conditions that we see regularly. I will mention about the others briefly at the end. The focus will be mainly diagnostic clues. We will not cover management or treatment a lot because we don't have time for that. My main objective will be highlighting the importance of recognizing clinical genetic clues, which may lead to hypothesis-driven genetic testing. And the clues will be marked with a red flag throughout my presentation, and you will see this red flag when I want to highlight the clues. So with that, I would like to go ahead and start with my first case. I saw this individual at Foothills Medical Center Emergency Department in July last year. She came with low pulse rate going on for a few months, some chest heaviness and shortness of breath. She's otherwise completely healthy-looking female, but she had a brief admission in May 2024, and she has a diagnosis of first-degree AV block, which was made in October 2023. Family history is completely unremarkable. So this is her ECG in emergency. It is a slow heart rate, irregular rhythm, some T-wave changes, left axis deviation. It's probably AFib with slow ventricular conduction, but you may argue it may be flutter with, fine flutter waves as well. But certainly it is not normal. And she had also mild heart failure features as well. The hospital admission in May was due to abdominal pain leading to a diagnosis of splenic and kidney infarcts, which is pretty unusual for a healthy woman at this age. At that time, atrial flutter with slow ventricular response was documented, and this is in the absence of any medication like beta blockers or calcium channel blockers. Echocardiogram was unremarkable, apart from mild enlargement of atria. Cardiac MRI was completely normal. There was no fibrosis or any acute injury pattern. She was started on oral anticoagulation with a diagnosis of probably cardioembolic infarcts, and the plan was to follow up as an outpatient setting for potential pacemaker. So back to July 2024, there was mild troponin elevation We repeated cardiac MRI just in case if there is new findings for injury or myocarditis, but it was completely normal again. The presentation was atypical to me, and while we were in the emergency, we placed the genetic request highlighting the potential LMNA cardiomyopathy, despite having no features for cardiomyopathy, but take my word, it will end up with LMNA cardiomyopathy. And this is based on this tachycardia, bradycardia presence in this individual, which is pretty unusual, and high thrombogenicity of this condition. For that reason, we planned left bundle CRT, pacemaker insertion, to lower the chance of pacemaker-induced cardiomyopathy. And she did pretty well during follow-up. She was completely asymptomatic, happy, until we get the genetic test result. She was quite shocked to have a disease-causing variant in LMNA gene. We met with her again, decided to upgrade the device to ICD system. We made a referral to heart failure specialist, and also we asked her to get family members, first-degree family members, to have genetic testing. She has 12 years old daughter, parents, and one sibling. So with that, we'll discuss LMNA cardiomyopathy first. What is it? It is LMNA gene encodes a nuclear laminar protein in the nucleus here. If you can see my arrow, it is a very critical role there. Inherited as autosomal dominant fashion, and it is a loss of function variant. Males are affected more severely than females, and it is typical for high penetrance. It is considered to be 90-95% by seventh decade. In cardiology, when you have a disease-causing variant, penetrance may not be that high, but for this condition, it is a high penetrance condition, meaning that they will eventually show some evidence for disease. Okay, usually manifests in early mid-adulthood. AV block is typical for those presentations, and it is reported to be up to 84% as an initial diagnosis, for example, a first-degree AV block. And these findings may precede LV findings like LV fibrosis or systolic dysfunction, wall motion abnormalities by a few years. Atrial arrhythmias are very common, atrial fibrillation, flutter, atrial tachycardia up to 60%. And again, slow or very well-controlled ventricular response is typical, and it should raise suspicion regarding a genetic etiology. Some people may have CK elevation because of skeletal muscle involvement. I didn't mention here, but LMNA disease may have different phases. Some people may present with progeria, some people may present with cardiac findings, or even lipodystrophy. Very much increased risk of systemic embolic events, as we saw in our patient, and this is regardless of the chest VASC score. Ventricular arrhythmias are common, and it can be the first presenting symptom. DCM or non-dilated LV cardiomyopathy can be seen with or without scar, and they may have less response to CRT or GDMT, unfortunately. So this is from a very recent review highlighting the importance of cardiac presentation. Our individual had the first three complications already. Hopefully, she will not have the last three. Some important points to highlight is when you consider pacemaker, consider ICD because of the significant ventricular arrhythmia risk. So there is increased risk of emboli. If you have documented AFib and flutter, you need to start anticoagulation as early as possible. And early identification and referral to heart failure specialist will be important to start precautious therapies or lifestyle modification. For risk stratification, you can use a tool, LMNA risk score online for ICD decision. So when you see an individual with tachycardia, bradycardia syndrome together, especially if they are young and you don't have any other explanation, those are the common genes that we encounter. We'll touch on the red ones, LMNA, SCN5A, SGO1, and HCN4 today. The others are also known to be related to tachycardia, bradycardia syndrome. Okay, so before going to our next case, I would like to acknowledge University of Calgary, Libin, and Alberta for giving me a privilege to serve people in Calgary and in Alberta. And I would like to thank anybody working with or for those institutions. Okay, so our second case is a 42-year-old man. And the presentation is mainly because of known cardiomyopathy. He is pretty much asymptomatic. I saw this individual at South Al campus in my clinic. So past medical history is significant for IBS and chronic eczema. Unfortunately, his sister died at the age of 22, likely because of a SADS condition, sudden arrhythmic death syndrome. Reportedly, autopsy revealed scar in the heart. His cardiac MRI was abnormal, mildly enlarged LV with LVEF 35, normal RV and RVEF 35%, and there was diffuse subepicardial LGE. This is important to remember. He has Holter showing quite a bit of PVCs and non-sustained VT, up to 3% of PVCs. This is his ECG. It is again not normal. There is PVC. We see PVC every now and then, but if you see PVC on all the ECGs, it is not normal. T-wave inversions. So physical exam-wise, it was pretty much unremarkable apart from some findings that I will show you. He had some like a woolly or wavy hair, which is a marker of a DSP cardiomyopathy in some individuals. And more importantly, I see more frequently the skin findings of those individuals, especially hands and feet, but mostly feet. When you see here, there are this scaly appearance of thickening, like callus-like, but they are not completely callus. They are just abnormal skin findings. In the past, that was called as palmoplantar keratoderma, still in the same way, but we thought maybe this condition is mostly seen in autosomal recessive forms of desmosomal conditions like nexus disease or Carvajal disease, but we see more and more commonly in autosomal dominant fashion as well. So when I saw these findings with the family history and cardiac MRI result, I said this might be DSP cardiomyopathy. We placed a referral to medical genetics, specifically indicating what we think, because it might be important eventually. We organized primary prevention ICD, again, referral to heart failure specialist, and clinical family screening was recommended. So he had only one sibling. His brother also lives in Alberta. He came to see me, completely asymptomatic, past medical history, again, asthma and eczema. There was no cardiac imaging available at that time, but he told me that he had an echocardiogram recently, and reporting physician said it looks like a little bit abnormal, and cardiac MRI was requested by that person, and cardiac MRI done a few days later after I saw him. This is his ECG. Again, there is a PVC there. You can argue about some P waves in inferior leads, maybe small amplitudes of QRS in the inferior leads. And this is his exam. Again, he has these findings in the feet. This is not new, like this is, as long as they can remember, they have these findings. And again, like I said, there's a high chance you will end up with the cardiomyopathy. An MRI came back again, low EF, 46%, normal RV, RVEF, again, decreased 45%, and extensive scar in the heart. So the wife was also with him that day, and I asked whether they have any children. She said, yes, they have 3, and 2 are twins, actually. And I asked if they had any skin lesions like that. Unfortunately, 2 of them, the twins, had it. And a referral was placed to pediatric cardiac electrophysiology. They eventually got the diagnosis of cardiomyopathy, not only clinically, but also genetic variant was found in that family, and cascade screening also showed that both the brother, my index patient, and the children of the brother also has this cardiomyopathy. They all have ICD now. They are doing well. So what is DSP cardiomyopathy? What is DSP? DSP stands for desmoplakin. Desmoplakin is one of the desmosomal proteins right here. LMNA was here in the nucleus, in the nuclear membrane, but these desmosomal proteins are close to cell membrane. They behave like a glue of the heart muscles to put them together and keep them together. The most common desmosomal gene disease we see is plakophilin. This is PKP2 and gives a typical presentation of ARVC. Desmoplakin is the second most common, but when we discover more individuals, it might be a really common condition as PKP2. The other desmosomal genes are also here. It is also a typically loss of function condition and autosomal dominant inheritance. So there is a recent registry sharing their information with DSP cardiomyopathy. They had 800 individuals following for 3 or 4 years. And I would like to just highlight the presentation of the phenotype. We always thought maybe DSP is kind of left heart disease. It presents like an ALVC, but it looks like it is not the case. 37%, it will be like an ARVC phenotype. About 7%, it will be DCM phenotype. There may be no enlargement, and this is called non-dilated LV cardiomyopathy, and up to 24% can present with that way, and 32% may present no findings for cardiomyopathy, but they may still have heart failure and ventricular arrhythmias, up to 0.5% per year for ventricular arrhythmia. So this is also one of the arrhythmogenic cardiomyopathies that we see in genetic arrhythmia clinic. So there are two unique features of this cardiomyopathy, and I highlighted the hot phases with red flag there. So this is pretty like a unique condition. Some of the patients may present recurrent chest pain and findings of myocarditis. And you may see any findings that you may see during myocarditis, like shortness of breath, arrhythmias, chest pain. It is found to be 1.3% per year in that registry. Pathogenesis and trigger poorly understood, but exercise can have a potential trigger for this. And this cardiomyopathy is also high risk for ventricular arrhythmias and heart failure. Again, there is an online risk stratification tool you can use. Again, being a female, for this cardiomyopathy is unusually a risk factor for ventricular arrhythmias. Mostly when we have cardiomyopathy, it is being a male actually more risky, but in that situation, interestingly, female gender is unlikely one. So those skin findings, initially thought to be autosomal recessive forms of the conditions that shows, like Carvajal, DSP, autosomal recessive disease, or JUP, nexus disease. But we see more commonly now when we pay attention to those skin findings. It is up to 44% in the registries, often misdiagnosed as psoriasis or dermatitis. It is interesting to note that the penetrance of those conditions are even up to 100% in the families. That means you may see those skin findings and heart may still look normal, but when you have genetic analysis, they may still have DSP cardiomyopathy. So those are the other individuals from other families that I follow in my clinic with DSP cardiomyopathy. When you tell them to take off the shoes and socks, you will see those findings in most of them. They are from different countries as an original and different backgrounds, but they share this abnormal skin findings that you can explain just being, pressure point calluses. Okay, so my second acknowledgement will be for HERO. HERO stands for Heart in Rhythm Organization. This is a Canadian network established in 2016 by Dr. Andrew Erkan. So what we do with this network, we try to increase the awareness, knowledge about inherited cardiac conditions to prevent tragedies mainly, and share the information with the other sites and the rest of the world. So here are doing pretty amazing job with yearly regular meetings, presentations, and publications. Okay, so I think I'm doing well from the time, and we will go to our third section to discuss one of my favorite genes, which is called SCN5A. So the involvement of myself in that patient care was reviewing the chart before pacemaker implantation. He was admitted in Rockview Hospital in October 2023. 65-year-old man admitted with chest discomfort, previous history of LAD stent for typical angina pectoris in 2021. He has hypertension, dyslipidemia. He quit smoking 10 years ago, and he has first-degree AV block. It is a common finding, I know, but it is important to pay attention when you think about genetic heart conditions. There is a recent unexpected death of the nephew because of heart attack, so you have to ask detailed questions whether this is really like a coronary obstructive disease or a sudden death, but it was suspicious too. Troponin was not elevated. Eventually, cath did not show any obstructive lesions, no significant progression, and echocardiogram was normal. The reason this individual was booked for pacemaker implantation was this. When he was in the hospital, he had this 9-second symptomatic pause. It doesn't look like vagal at all. It is clearly pathologic AV block. And for that reason, he was scheduled for pacemaker surgery. The day before, I was reviewing the chart and I saw this ECG. Yes, PR is long, but I paid attention to V1 and V2. Like, it is not typical for Brugada, but it is not normal either. I thought, like, is it or not? If you have this suspicion, you will just move the precordial leads to second and third intercostal space and fourth, and you will repeat the ECG, and you will sometimes have this diagnostic typical type 1 Brugada pattern without much suspicion. So this changed our plan a little bit. Instead of giving regular conventional endocardial pacemaker, we planned left bundle branch area pacing for possibility of increased LV pacing in the future, and some people may have a cardiomyopathy with SCN5A situations. We put a referral to medical genetics for SCN5A gene testing because the only gene has a good gene disease association evidence is SCN5A for Brugada. And we consult him regarding precautions like avoiding alcohol, cocaine, fever, Brugada drugs, and avoiding heavy meals before going to bed especially. And we encouraged him to have the family to have some clinical screening. So this will bring us to SCN5A gene. This is the main gene that, the main channel that, sodium channel that we see in the heart for depolarization. SCN5A encodes the alpha subunit of this sodium channel called NAV15. It is mean like a voltage gated sodium channel. This makes our phase 0 depolarization in the heart. And there is an alpha subunit and there is a beta subunit. SCN5A produces this alpha subunit. As you see, like there are 4 domains. This is the pore forming of the channel. Eventually, sodium will go into cell through this channel. We have 6 segments of each domain. The S4 segment is the selectivity or, it is the voltage sensing part of the channel. Those loops between S5 and S6 makes the sodium selectivity. When you see that channel in the pore shape, you will see there is a gate made by this loop between domain 3 and domain 4. And this is the gate that behaves like an inactivation gate and activation state. Of course, when the channel is activated, you have sodium current going into cell, and then this gate closes the gate eventually, and then phase 0 ended. So if you have a problem in any parts of this channel, you will have either loss of function or gain of function of this channel, and you will have different kinds of phenotypes, different kinds of diseases. Again, SCN5A encodes the alpha subunit of this voltage-gated sodium channel, which is predominant channel in the heart. It is responsible from phase 0, this rapid depolarization phase of the action potential. The conditions mostly inherited as autosomal dominant again for SCN5A. And you can see arrhythmia or cardiomyopathy or both in the individuals who have SCN5A disease-causing variant. So We can divide the phenotypes, the conditions we see, into two broad categories. One is loss of function, the other one is gain of function. So the prototype or the most common loss of function phenotype is Brugada, and gain of function, it is congenital long QT syndrome type 3. But Brugada is not the only one. We can see DCM, arrhythmogenic right ventricular cardiomyopathy, progressive cardiac conduction disease, atrial fibrillation, sinus node dysfunction, or idioventricular ventricular fibrillation with loss of functions variants. Individuals may show only one of those, or they can show a few of them as an overlap syndrome. Gain of function-wise, congenital long QT syndrome type 3 is the most common or well-known one, but there is a new entity called multifocal ectopic Purkinje-related premature contractions, or in brief, MAPPC, and we'll see an example of MAPPC in a second as a gain of function variant. So it is interesting that SCN5A may behave a host-dependent way. That means if you have an individual with long QT syndrome type 3, a family member may have MAPPC, or they may choose one of those. They may have Brugada or ARVC. So it's a pretty fascinating condition. Probably there are other genetic variants or modifiers affects the common phenotype, or maybe epigenetic environmental factors as well. So with that, we'll discuss a case with MAPPC, a 44-year-old man with recent genetic testing showing a gain of function, known gain of function in SCN5A gene. He came with like a mild palpitations. He was pretty much asymptomatic, but the reason he got this testing in the first place was family history. Unfortunately, his sister died at the age of 14, and suddenly, without any explanation, autopsy was unremarkable. This is the ECG. So it doesn't look too bad, too abnormal, but when you pay attention to those PVCs, they look unusual. Like when we see PVCs in ECGs alter, it is usually bizarre, large, tall. T waves are looking weird, but this is relatively narrow. The initial forces are very rapid. So this indicates this might be coming from his Purkinje system, conduction system, so that's the reason they are that narrow. His echocardiogram is unremarkable, but he has 7% of PVCs and atrial fibrillation in a paroxysmal manner. Again, it is pretty unusual. He is a completely healthy-looking person, no hyperthyroidism, nothing else to explain. MRI shows LVEF 56%, RVEF 47%, and no scar in the heart or no evidence for injury. Another day, another ECG shows different morphology PVCs on the single ECG. Another day, couplets, but they are bidirectional. They are not even same morphology. They are from different foci. And you can also show atrial fibrillation. Again, you can see this relatively narrow PVCs with rapid initial forces, which may indicate these are probably coming from his Purkinje system. And this is his father's ECG. Sorry, this ECG has not good image, but it is an old, very old ECG. But it is interesting to note that father has atrial fibrillation diagnosis and also frequent PVCs. Again, those PVCs are relatively narrow and rapid initial forces, and you can see also different focus origin here as well on this single 10 second of recording. So this is not usual. This may suggest some underlying genetic condition in family members having both those PVCs and sudden cardiac death in a young individual in the family. So this is a new condition, a rare condition, relatively underexplored disorder, first described in 2012, autosomal dominant, but this time it is gain of function variant in SCN5A gene. The typical feature is high burden of PVCs, but they are narrow. They are narrow PVCs, and you can see non-sustained VT as well. You may see atrial tachycardia. It can be multifocal atrial tachycardia, AFib, flutter, or SVT. Less commonly, you can see conduction issues as well, like sinus node dysfunction or type 1 Mobitz 2 AV block. Typically, there is no structural heart condition, but In rare cases, you may see some fibrosis in the MRI. So there may be evidence for PVC-induced cardiomyopathy, and it's usually reversible when you treat those individuals. Typically seen in young individuals, even in newborns, they can be asymptomatic. They may have palpitation, shortness of breath, syncope, or sudden cardiac arrest. There is no significant gender difference, and there may be a family history for DCM or sudden arrhythmic death syndrome. And it is also reported that you can suppress those PVCs at peak exercise. Treatment is pretty much sodium channel blocker. Since this is a gain of function in the sodium channel, it makes sense to think that they will work. And eventually, we have some evidence that flecainide seems to be working well for those individuals. And quinidine is another medication as class 1A sodium channel blocker. So I will just show you another family with SCN5A condition before going into our next session. This family has SCN5A disease. Again, the individual I saw was a 40-year-old woman with abnormal ECG, completely asymptomatic, history of vasovagal syncope. And the reason I am seeing her was first-degree cousin had sudden cardiac arrest in a different province due to long QT syndrome type 3. So then you automatically think this is a sodium channel gain of function variant in this family. But when you look at her ECG, absolutely it is not long QT syndrome. Corrected QT interval is 398, which is pretty normal. Of course, we don't decide on a single ECG, but there was no evidence for long QT syndrome. But the important finding was QRS was relatively wide, and PR was also borderline prolonged. So it is more like a loss of function behavior in that individual. Echocardiogram was normal. Interestingly, MRI showed some findings towards cardiomyopathy. So some wall thinning in the AV apical region and wall motion abnormalities in the heart. So now we have both some conduction disease phenotype plus cardiomyopathy phenotype. And interestingly, her son had spontaneous type 1 Brugada pattern, which is another loss of function phenotype in the SCN5A gene. Sometimes we do challenge tests for our individuals, for our patients. For my patient, we gave procainamide, which is a sodium channel blocker, to see if we can unmask a potential Brugada pattern. Those are prior to challenge test. So you can see this precordial leads in the second, third, and fourth intercostal space. After procainamide, you see you can actually show the type 1 Brugada pattern in her case. So now she has 3 phenotypes: drug-induced type 1 Brugada, cardiomyopathy, and some conduction disease. Despite the family member in other province having gain of function, she has loss of function in the SCN5A. Okay, before going to our next and last section, I would like to acknowledge my pediatric EP colleagues, Dr. Clegg and Friedman. We work closely, and they are taking care of the individuals younger than 18. And commonly, we serve same families together. And of course, medical genetics, and they are excellent geneticists and genetic counselors. A special thanks to them as well. Okay, so this condition is super rare, but super interesting as well. It's called chronic atrial and intestinal dysrhythmia syndrome. So we have seen some hair changes, some feet findings. Now we'll see our conditions might be also involving the gut. So in that condition, what happens is, for some reason, I will explain later, the pacemaker function of the heart and pacemaker function of the gut gets sickness. So it is SA node in heart, as you know, but it is called cells of Cajal in the plexus of the intestines gets the sickness. And a case report also revealed 2 cases that had also have some vascular problems in the brain as well. So this may, in the future, we may see the name changing a little bit, but currently the name is chronic atrial and intestinal dysrhythmia syndrome. Okay, so what is GI phenotype in those individuals? So typically they have recurrent paralytic intestinal obstruction. It is actually pseudo-obstruction. Frequent ER visits and hospitalization for that, need for recurrent endoscopic decompression, chronic GI symptoms like abdominal pain, vomiting, and weight loss, often unnecessary surgical interventions, failure to thrive and malnutrition can be seen because of that. And unfortunately, some of them will need chronic TPN, total parenteral nutrition, for their condition. When we look at the cardiac phenotype, so you may see atrial cardiomyopathy, sinus node dysfunction, and atrial tachyarrhythmias. So atrial cardiomyopathy is seen in all individuals. Early onset, even in children, can be seen, and there is severe biatrial enlargement. Interestingly, there is no AV block. There is no ventricular findings in that condition. Sinus node dysfunction can be progressive, and atrial standstill can be seen. With respect to atrial arrhythmias, flutter, fibrillation, or atrial tachycardia, which can be multifocal as well. So they may have tachybrady syndrome again, and it is difficult to manage because when you give beta blockers or antiarrhythmic medications, they usually have severe hypotension and bradycardia, and usually a pacemaker is indicated. The challenge will be to give a pacemaker that will not get infected because of this chronic TPN or surgical interventions, but fortunately we have options nowadays, including leadless pacemaker, has a low chance of infection. And there may be a chance that increased thromboembolic events as well, but it needs more evidence to prove. Neurovascular phenotype-wise, the case report showed 2 individuals having cerebral small vessel disease. It's mainly posterior circulation. Cerebellar microbleeds are most common in that scenario. And the major challenge will be to introduce anticoagulation if they have indication for that because of those bleedings. Again, you will need to explore other options, including left atrial appendage occlusion devices. Okay, why it is happening? What is this condition? So true prevalence is unknown. Autosomal recessive this time, seen in young individuals. And the gene responsible from this is SGO1. It is Shugoshin-like 1 protein. So expression is in sinus node and mesenteric nerve plexus as well. So that's the reason we have these 2 important phenotypes in those individuals. There is only one known variant, which is a change of adenine with guanine in 67th position, leading to a change in the amino acid from lysine to glutamate. Interestingly, this is a French-Canadian founder variant. So this was first described in Canada, in Quebec. It is found that the couple likely married in France in 1620. But there is another family found, Swedish family, and then they went back and they guessed it is actually 900 years ago they share this common ancestries and probably originated from there and then moved to Canada in that way. There is full penetrance in homozygous individuals, but expression may be variable. So that's the important part we need to keep in mind. You may see some gastrointestinal findings, not that much severe, but early onset tachybrady syndrome. So it's nice to keep in mind that this might be one of those conditions. There is no evidence for heterozygous state. That's the reason I think we don't see that condition that frequently. Now I will bring you back to our medical school lectures about mitosis and cell division, because this is what is happening here, what's the problem is. So this is pro-metaphase of the cell division, and we have metaphase and anaphase. So we have sister chromosomes or sister chromatids here together attached to each other, but eventually they will get separated in the anaphase to produce 2 daughter cells. It is important for the cell to spend some time here with the centromeric part are still attached. So they detached from here in the arms, but the centromeric part should stay for a while for the cell to get ready for division. So think this as a last kiss of those sisters to each other before separation. So if this centromeric attachment is too long or prematurely ends, you may end up with some abnormalities. And you can see it here. X-shaped feature of chromosome appearance will be the normal one in metaphase. The others are abnormal, like closed, looking like that, or they are completely separated, or they look like a railroad. They are not X-shaped. So the condition in our cohesion problem is railroad. It's been shown from fibroblasts from individuals who got this condition. The main problem seems to be a railroad appearance in that process. There are other syndromes that goes with this cohesion problem, but the relevant one for us with cardiac phenotype will be this chronic atrial and intestinal dysrhythmia syndrome. And you can see this immunofluorescent image of a rat cell. See, this is just a normal cell with microtubules here. The blue part is condensed chromosomes, and this is prometaphase. You have spindles and two poles are appearing here, and nuclear envelope is gone. Now those microtubules have access to chromosomes. This is metaphase. The chromosome lines up in the equator of the cell in the midline, and you have good spindles here, two poles, and this is anaphase. Now they get separated into two daughter cells. So molecular mechanisms is only partially elucidated, and what we know is there is increased senescence in those cells. There is high turnover because of most of the cells are spending time in metaphase. And eventually you have increased TGF beta signaling and fibrosis. I think this is the main reason we are having this sinus node dysfunction, atrial arrhythmias, and intestinal findings. You can see intestinal cells of Cajal in the neuron plexus of the gastrointestinal system here. And more recent studies also show there is like an ion current problem in the heart as well, such as HCN4, which is the main responsible pacemaker flow of the sinus node, or inward rectifier potassium current, which is very important for resting membrane potential. Okay, I think I have only two more slides left. I will acknowledge two important people in my life, giving me energy to get up early and work hard every day. Okay, so those are the other conditions I see in genetic arrhythmia clinic. We can't mention all of those, but a few of them to be highlighted. DSC2 homozygous cardiomyopathy is seen relatively common in Alberta. And actually it was defined in Alberta proudly. LEMD2, again, it is autosomal recessive condition, and we can see it in Alberta and north parts of USA. TMAM43, a Newfoundland condition first described in Newfoundland. It's very, very malignant heart condition with respect to arrhythmias. We have a very low threshold to offer ICD, despite having no features of cardiomyopathy. And calcium release deficiency syndrome, it's a very, very new condition because of RYR2 genetic loss of function. We are lucky to have Dr. Wayne Chen in Calgary, who had great contributions for discovery of this condition, but still we are doing registries and studies to understand that sudden cardiac death condition better. So all those conditions may have unique presentations, unique clues that will lead to right diagnosis. I can't cover all of them, but I will mention some of them. One disease in that list will present with juvenile cataracts. Pretty uncommon, but when you see that, you will keep in mind that there may be a cardiomyopathy going on. One of those conditions will present significant arrhythmias during swimming. You may have cardiac arrest, and it looks like swimming is a specific trigger for that condition. Another condition from that list will have significant arrhythmia presentation when startle happens, like sudden sounds or scary moments. And postpartum period seems to be a little bit tricky and more risky. Another condition will prevent multiple aneurysms in the heart, which is, again, not typical and pretty unique presentation. Another one will present some facial dysmorphic features, some hand findings, and toe findings like clinodactyly or syndactyly. So I encourage all residents and fellows to come and join me in a genetic arrhythmia clinic to learn and diagnose those individuals by these clues. And those clues will not only lead to accurate diagnosis, but also we use them for treatment, for lifestyle changes and patient counseling. Okay, so this is my last slide. Main take-home messages. First, genetic cardiac conditions frequently present with arrhythmia, and it can be the first one and the dangerous one. Timely recognition of genetic clues can lead to gene-specific diagnosis, and timely diagnosis can lead to precision management of the index individuals and their families, which can save lives or prevent significant outcomes. So depending on the gene we have different lifestyle modifications like exercise prescription, whether to go swimming alone or not, whether to avoid fever, lower the fever, or prevent sudden alert sounds in the bedroom or not, or when to offer ICD, when to refer to heart failure specialist. Are there any reproductive options for the young families? So it's very important to get the bottom of the genetic diagnosis when you see a family with arrhythmia that might be genetic in origin. And thank you for attention.
Thank you very much, Erkan, for that wonderful talk. We will open up for questions now. I'm going to open the chat box if anyone wants to put questions in there. We already have one question there, or just speak up. And we'll start off with asking the room here. I'll just turn on the mics.
Sure.
Vikas.
Yeah, thanks, Erkan. That was a great presentation. I'm glad you're here, so I can send these patients to you.
Of course.
I had two questions. So the first one was, I think you mentioned a lot of the inherited channelopathy seem to have a prolonged PR sometimes. Because of an atrial cardiomyopathy that we just can't diagnose on or something, or what do you think that is?
Yeah, the question is, some people have PR prolongation, and what is the exact reason of that? So I think it depends. If it is atrial cardiomyopathy, then it is known that the PR prolongation is before electricity comes to AV node and make the prolongation there. So typical example will be myotonic dystrophies. It is very typical that you have PR prolongation in those individuals. And it is probably likely due to atrial cardiomyopathy rather than having AV node disease. But having said that, those individuals also have bundle branch block and other conduction disease. For the cases I presented, I think it is pretty much in the conduction system because SCN5A is abundant in the His-Purkinje system, especially in the bundles. They may cause his bundle problem, but SCN5A actually does not have a lot of presence in the sinus node or AV node. So I think the short answer is that probably some of them have intrinsic conduction system disease. The others have atrial cardiomyopathy, and SA block happens because of that. It's a conduction exit block, or it's an basically entrance into AV node problem.
Third case, I think you're going to put in a CSP pacemaker. If the testing came back positive, would you make it a different?
Yeah, so the question is, when you put a pacemaker in an individual with Brugada, having a genetic test positivity for SCN5A would change your mind for ICD? The answer will be likely no. We'll probably just continue with pacemaker because ICD decision for Brugada is rarely affected by your genotype. So we pretty much follow the same treatment for gene positivity or negativity in case of Brugada. So big risk factors will be unexplained syncope or cardiac arrest or documented VT for Brugada patients.
Why don't we turn to one of these questions?
Okay, the question is, do you recommend every patient with hereditary palmoplantar keratoderma must be screened for dysrhythmia or cardiomyopathy? So I am aware there are other types of familial palmoplantar keratoderma without any cardiac phenotype. So I think it depends on the presentation. If there is suspicious family history, or if you have abnormal physical exam, otherwise from cardiac perspective, abnormal ECGs, or maybe echocardiogram findings, you may consider doing more. But if it is a known gene going purely for non-cardiac phenotype, I don't think you have to go deep. Another question.
I'll just flesh that one out a little bit.
Sure.
My question. So, reading between the lines of your talk, your approach is you have a series of red flags for patients referred to you for genetic testing. Is that generally what gets you to genetic testing? Kind of you have a slate of red flags that you look for, or would you advocate as genetic testing becomes more available that we expand its use? What's your kind of thoughts on who goes?
Yeah, so genetic testing needs to be considered broader. Like if you have suspicion that this might be a genetic background, you don't have to have any of the clues. If you have strong family history, or if you have an individual unexplained DCM without much risk factors, I think it's reasonable to consider. I think genetic testing should be broadly and more commonly used. The clues I have shown here so far, like it's extra evidence, and it helps you to make an hypothesis when you go to genetic testing. It helps. So let's say the first case I presented in emergency, I thought it might be LMNA, or the second case with the SPA. This is what I expressed to medical genetics department. And let's say you had a VUS. They came up with a variant. They cannot classify whether it is benign or it is disease causing. Then in my mind, at least, it is not a VUS. I think it can't be VUS. I think it is potentially a disease-causing variant, and I think in that way. And I try to increase the evidence to upgrade the VUS to likely pathogenic potentially. And the way I will do that, I will bring the other family members for segregation, for example. If I prove it segregates in the family, meaning like if I show the condition in the family and all those individuals actually have this VUS, then it will be pretty much strong evidence towards pathogenicity. It helps for hypothesis generating, and in my mind, it may help me to manage those individuals. Like I may follow them closer if there is any variant in those genes. It may affect my isolation decision. But in short, you don't have to have any of the clues to suspect genetic testing if there is indication otherwise. Okay, another question is, KIR21 mutations may play a role in some of the arrhythmogenic diseases. Have you seen proarrhythmia with class 1C in some of the patients, specifically long QT syndrome or Anderson-Tawil syndrome type 1? So this is an invertly rectified potassium current that we can see with KCNJ2 gene variants, and typically gain of function will cause Anderson-Tawil syndrome, and loss of function may lead to, Anderson-Tawil syndrome, which is known as long QT syndrome type 7. So in those individuals, treatment will be mostly beta blocker, and we use flecainide more and more. So for Anderson-Tawil syndrome, flecainide actually have some antiarrhythmic features, and it helps because it's been shown that it is not only potassium flow issue with Anderson-Tawil syndrome, and also sodium current also gets affected. It's more complicated than we think. It is not only a potassium issue, but in short, we use flecainide in ATS, Anderson-Tawil syndrome type 1 patients, and I haven't encountered any arrhythmia with flecainide, which is a class 1C medication.
Well,
can I ask a question here? In the community symphony of health, is that okay?
Yeah, go ahead, Andres.
Sorry, I had to interrupt, but any questions here from you guys? I just want to make a comment. First of all, a great talk, Erkan, thanks for that. We see tons and tons of patients with atrial fibrillation, some atrial enlargement, and they are younger than 60. We see tons of people with PVCs, maybe normal or mild LV dysfunction. And now if I go back to DSP, it seems it could be the PVCs could have a benign appearance, like an inferior axis, you think it's outflow tract,
but they end up actually having ARVC or whatever it is. So do I understand right that we probably should have a lower threshold if we have those suspicions to send for genetic testing and see what comes out of that?
Yeah, I chose those arrhythmias because they are common, AFib or PVCs. Of course, it is not possible to run genetic testing for all those conditions. I think the important clues will be, is there any explanation for this arrhythmias? Like if you have severe hypertension, sleep apnea, or diabetes, so it's unlikely that you will have a high yield. But as I show those cases, like if they are young, there is no clear explanation, they are fit, no hypertension, there is no explanation. If you have an age cutoff like a 40, 50, I think it will be reasonable to consider for AFib perspective. So there are some publications now focusing on atrial fibrillation, familial background, genetic background, and yield is not great, but if you have a certain cutoff of, let's say 40, 50, no risk factors for AFib, and some other maybe suggesting findings, family history, I think yield will be higher. And the most common genes in that scenario will be either LMNA or titin cardiomyopathy genes, KCNQ1, KCN5A. Those are the most common genes. But when you look at the gene disease association in ClinGen website, this is a website that you can go and type your gene to see if there is a strong disease gene association. You will not see a lot of strong or definite evidence for AFib yet. But I agree in that respect that if you have an individual with no explanation for AFib, it might be reasonable to have a cutoff in your mind and send for genetic testing because it will change the management dramatically. For PVCs, again, like classically we were thought that exercise suppression of PVC can be a benign thing, but we know now that it is not true for all the cases. When you have unexplained PVCs, if they are looking non-typical origin, like they are not from RVOT or outflow tract, they are coming from different locations, they look narrow, there is some family history, or they are multifocal in origin. And then first you will do your classic standard investigations, including echocardiogram, MRI. And if you have further evidence for potential genetic background, I think it's reasonable to send them for genetic testing.
Great. So thank you very much, Erkan. That was a wonderful talk. We're top of the hour, so I think we'll shut off questions now. So,
great.
But thanks so much for coming out. Yeah. And this all.